So we'll move on to the next type of hemolytic anemia, which is sickle cell anemia. So what is this sickle cell anemia? Sickle cell anemia is also hereditary hemolytic anemia. Okay, so as the name suggests, sickle cell anemia is named so because the RBC assume sickle-like morphology. Okay, so the RBC morphology becomes sickle-like, right? And this is again hemoglobinopathy. So there is a disorder with the hemoglobin structure, right? So what is the defect in sickle cell anemia? This occurs due to a mutation in the beta chain of the hemoglobin, where glutamic acid is substituted by valine. Glutamic acid is substituted by the amino acid valine in the beta chain of the hemoglobin, resulting in this characteristic sickle cell anemia. Okay, so this is a type of hereditary hemolytic disorder. It's a hemoglobinopathy where glutamic acid is substituted by valine in the beta chain of the hemoglobin. Okay, so this usually happens in the 6th or 7th position. Alright, so this is sickle cell anemia. So let us understand about the epidemiology of sickle cell. So sickle cell usually is characterized by the following haplotypes. So we have the Benin, Bantu, Senegal, Cameroon and the Arab Indian. So most of the sickle cell anemias are usually found in the Middle East, in the Africa as well as the Indian subcontinent. Okay. When we speak about the Indian subcontinent, sickle cell anemia is more common in the Middle India as well as the Bengal and Northeast Indians. So there is a lot of sickle cell population there as well. So let us understand the pathophysiology of sickle cell anemia. So the major mutation is that the triplet codon, there is a mutation in CAG where in the beta chain in the 7th position glutamic acid is substituted by valine. Okay. Now this defect does not result in sickle cell chronically, but what happens is certain times when there is a trigger factor like hypoxia, it basically results in polymerization of the RBCs. So oxygenated RBCs usually are normal in shape, but when there is hypoxia, the deoxygenated RBCs undergo sickling and their morphology becomes like a sickle. Okay, so what happens as a result of this sickling? Right? So what happens as a result of the sickling is that these sickle cells basically go further downstream and they cause obstruction of the vessels, right? So they become a clump and they obstruct the vessel, reduce the blood flow and it results in vaso-occlusion. That is one of the things. Secondly, the sickle cell membranes are not very stable and hence they undergo hemolysis and there is increased consumption of nitric oxide. Right, so they undergo hemolysis, there is increased consumption of nitric oxide and there can be vasoconstriction, right. So because of this vasoconstriction and vaso-occlusion, this can result in decreased blood supply to multiple organs in the body and over a chronic period of time, it can result in a lot of damage to multiple organs. At the same time, the hemolysis can also result in precipitous drops of hemoglobin often. Okay, so this is about the entire pathogenesis of sickle cell anemia. So let us understand the types of sickle cell anemia. So for that we have to understand what are the normal fractions of hemoglobin. So in a healthy adult individual, what are the normal types of hemoglobin which is present, normal fractions of the hemoglobin. So we have hemoglobin A which accounts for 95 to 98% of the hemoglobin. Then hemoglobin A2 is 2 to 3%. And fetal hemoglobin is usually less than 2% in a healthy adult individual, right? So sickle cell anemia can either be a sickle cell trait, which is a milder form, which is usually heterozygous in nature, and sickle cell anemia, which is more of a severe form. Okay, so in a milder form, what is the fractions of hemoglobin? So here you can see that HbA is 60% and HbS is 30 to 40%. Right, so the fraction of HbS hemoglobin or the sickle cell fraction is usually around 30 to 40%. But if you see in a sickle cell anemia where it is a more severe form, here the HbS fraction is more than 75%, HbA2 is 3 to 4% and fetal hemoglobin is increased as a compensatory mechanism and can go as high as 25%. Now, sickle cell can also have overlap with certain other types of hemoglobinopathies such as thalassemia. In thalassemia, there is a quantitative disorder of the beta chain where there is decreased beta chain production of the hemoglobin, right? So, this can be classified as beta 0 and beta plus thalassemia, right? So, in this beta 0 thalassemia, what happens is that there is a sickle cell trait along with beta 0 thalassemia. Beta 0 thalassemia means that there is complete absence of the beta chain, and here again the sickle cell fraction is more than 75%, HbA2 is 5 to 6% and fetal hemoglobin is 2 to 15%. Right? But if you see a beta plus thalassemia, which is often an intermediate form where there is some quantity of beta hemoglobin, beta chain of the hemoglobin, but not enough. So here there is an intermediate beta-thal along with a sickle cell. So here again the sickle cell fraction can be more than 60%, but you can see that there is HbA which is still intact, which is usually more than 90% in a normal individual. It is present, but it is reduced and it is about 5 to 40%. Again, the fetal hemoglobin as well as HbA2 fractions will also be increased. Okay, fine. So, this is about how sickle cell can be found overlapping with thalassemia intermedia as well as a thalassemia major as well. Okay, now how do you diagnose this sickle cell anemia? So, let us understand how do you diagnose sickle cell anemia. So, the test that is done, this is basically based on the hemoglobin electrophoresis. Okay, so diagnosis is basically done based on the hemoglobin electrophoresis. So, let us see the first example. The first example, you can see that there is about some amount of HbA, right? So, HbA is present, HbA2 is present, but you find evidence of some amount of HbS as well, right? But you can see that the fetal hemoglobin, which is usually expected here, is not there. So, this is an example of sickle cell trait, okay, a milder version. But in severe, if you have to see a sickle cell anemia, in a sickle cell anemia, right, in severe where there is a severe sickling issue, then here you find that there is a peak for the fetal hemoglobin as well, right? And here you can see that there is HbC plus HbS evidence, which is an HbSC overlap. Okay, so this is how you use the electrophoresis, hemoglobin electrophoresis, to identify and differentiate between sickle cell anemia and sickle cell trait, right? So, sickle cell anemia will show that there is evidence of HbF also increasing as a compensation as compared to sickle cell trait, right? Then, what can you see on the peripheral smear? This is the characteristic peripheral smear appearance of the sickling of the RBCs. Okay, fine. So, this is about sickle cell anemia. So, what all have we learned till now? We have learned what is sickle cell anemia, what is the defect, right? And we have looked at how will you interpret the hemoglobin electrophoresis in the diagnosis of sickle cell anemia. Okay, what is the pathophysiology? The pathophysiology is that whenever there is sickling, the deoxygenated hemoglobin basically results in the sickling, and this can cause vaso-occlusion. It can also cause vasoconstriction because of nitric oxide consumption, and there can be hemolysis as well. So, let us look at the clinical features and the various complications which can be associated with sickle cell anemia. So, sickle cell anemia is more commonly seen in males, and it can be seen in any age group, more commonly in the younger age group 20 to 30 years. Okay. So, the first complication with which a sickle cell anemia patient can present is what we call as the acute painful episode. So, in this acute painful episode, due to unknown reasons, there can be severe pains predominantly in the torso, right? So, there can be severe pains which are usually unexplained pains predominantly in the torso, and what is the mechanism that has been proposed is that there can be vaso-occlusion and there can be vasoconstriction in those areas which can contribute to the pain, right? So, there can be severe unexplained pain in the torso. But what is the thing that we have to watch out for? That a severe acute painful episode can be associated with an increased risk of cardiac arrest, right? So, whenever a patient of sickle cell anemia presents to you with severe painful episode, then you will have to admit him and monitor his vitals, monitor the cardiac rhythm, and keep him under care. So, how will you manage this severe acute painful episodes? These painful episodes usually require IV opioids. NSAIDs can be tried, but most often they are not responsive to paracetamol and NSAIDs, and IV opioids are required. And always monitor them well for any desaturation. If there is evidence of hypoxia or desaturation, then oxygen supplementation may also be required. Okay, so this is one of the clinical presentations with which they can present an acute painful episode. Okay, fine. Then what is acute chest syndrome? The second complication with which a sickle cell anemia patient can present is an acute chest syndrome, which is usually characterized by pneumonia-like illness. So they can present with an acute episode of fever with cough, and chest X-ray can show the evidence of fleeting infiltrates. So there can be evidence of fleeting infiltrates, right? But you may find that there is usually no evidence of any infection in the background, but you may have to treat them with empirical antibiotics just to cover for them. Okay, so acute chest syndrome is basically a pneumonia-like episode, and many a times it can be rapidly progressive, and if there is hypoxia, then oxygen supplementation may be required, and if the patient worsens on that, then he may have to be put on a mechanical ventilator as well. Okay, so management of acute chest syndrome involves oxygen supplementation. Okay, apart from oxygen supplementation, you have to monitor the Hb and try and maintain the Hb at a level of around 10 milligrams per deciliter. Okay, and you may have to give them supportive treatment with your RBC transfusions, and you may have to cover them with antibiotics if the diagnosis is not very clear. Right? So acute chest syndrome is a pneumonia-like illness. Then the chronic complication of sickle cell anemia can be chronic onset osteonecrosis. Right? Because of the chronic vaso-occlusion, there can be multiple vaso-occlusive episodes. Because of this multiple vaso-occlusive episodes, the head of the femur especially is the one which usually gets affected, and there can be osteonecrosis of the femur, and over time they may complain of persistent pains in the hip joint, decreased mobility in the hip joint, and you may have to replace the joint itself. Another dreaded complication of this osteonecrosis is that the bone spicules can get separated and they can embolize, right? So if a patient is presenting to you with an acute chest syndrome with hypoxia, you may have to rule out an embolism of the osteonecrosis as well. Okay, so this is osteonecrosis. Then let us look at one other of complications one by one. So you have to remember that vaso-occlusion can happen any artery, and hence the arteries to the penile region is also affected. There can be priapism, which is usually seen in 30% of the males. So most often this is episodic of short duration, but is usually severely painful, and over the course of time it may be associated with impotence as well, and it is associated with hemolysis, right? So over chronic time, you can give alpha-adrenergic agonist, but most of the time you may require a neurology consultation as well. Then, as sickle cell anemias can have episodes of vaso-occlusion, you may have silent strokes, right? Strokes and silent stroke-like episodes can be present, which is seen in 10 to 15% of the individuals. Predominantly, it starts in childhood and progresses in adulthood, and this can result in neurocognitive abnormalities in adults, and again it can be associated with hemolytic episodes. So the most important screening test is now, which has been advocated as a part of the guidelines, is transcranial Doppler screening in children aged 2 to 16 itself, right? So this is basically done because you start blood transfusions earlier in these patients to prevent repeated episodes of stroke. So you do a transcranial Doppler evaluation and start it at a younger age, at age of 2 to 16 itself. And if there is a high risk, right, so you find evidence of decreased flow at a younger age itself, then they may be transfusion dependent. So it has been found that repeated blood transfusion usually decreases the risk of stroke in such individuals, and hence they may have become transfusion dependent. Otherwise, certain drugs like hydroxyurea can also be initiated. Then third, you can have gallstones, again because sickle cell anemia can result in both intravascular as well as extravascular hemolysis. So extravascular hemolysis can result in pigment gallstones, which can be seen in up to 40% of the individuals, right? So if they are asymptomatic, most of the time we do not do anything. If they are symptomatic, they may require a cholecystectomy. Then you can have hepatic diseases. More than 80% of the patients have hepatomegaly. They can have intrahepatic cholestasis. Okay. Apart from that, sickle cell anemia patients may also get repeated blood transfusions, and hence it predisposes them to iron overload. There are certain other risks associated with blood transfusion as well. Transmission of hepatotropic viruses. So there can be viral hepatitis as well, right? Also, because of the extravascular hemolysis, you can have damage to the liver and there can be RBC sequestration, right? So if there is intrahepatic cholestasis and worsening of LFTs or liver failure, exchange transfusion is advocated, okay? And end-stage liver failure, you may require a transplant. Then there can be associated nephropathy as well. So up to 30% of the adults can be affected, okay? So what happens is sickle cell anemia, the sicklers can go and cause vaso-occlusion. There can be vaso-occlusion at the level of renal arteries, right? So the most important site which is most prone to this is the renal medulla. So there can be complete damage to the renal medulla. There can be damage to the tubules. So there can be some amount of nephrotic range proteinuria in the later stages as well. So it's very, very important that we screen them for microalbuminuria as early as 10 years of age. We avoid NSAIDs and start them on ACE inhibitors for albuminuria, right? So that is about nephropathy. Then what about the lung manifestations? So when you have acute lung manifestations, you can have acute chest syndrome, but in chronic disease, they can be restrictive lung diseases, right? And 5 to 10% can also develop pulmonary hypertension because of repeated vaso-occlusion in the pulmonary artery, right? So you can have pulmonary hypertension and right heart failure as well. Then sickle cell anemia can also affect the retinal vasculature, resulting in retinopathy, right? It can be seen again in 30% of the individuals. There can be vitreous hemorrhage and retinal detachment, which can result in blindness. And again, you will have to start screening by 10 years of age, and you may have to do a photocoagulative therapy if there is evidence of sickle cell retinopathy. The characteristic name that we use in your sickle cell retinopathy is called as C-fan appearance. Okay, so sickle cell retinopathy is what appearance? It has a C-fan appearance. Then you can have acute anemic episodes. Most of the time, acute anemic episodes are usually triggered by a viral illness like a parvovirus B19 deficiency, or it can be due to splenic sequestration, or it can be due to hemolytic transfusion reactions, right? So RBC transfusions may be required. PRBCs may have to be given during a hemolytic episodes, especially if the hemoglobin is dropping rapidly, and try to maintain the hemoglobin at around 10. Okay, fine. In more severe episodes, if there is severe hemolysis, you may also require exchange transfusion, right? Over the course of time, if there is multi-organ failure, very severe acute chest syndrome, confusion, sepsis, CNS, liver involvement, then exchange transfusion may be required. So this is about the various clinical features and various complications of sickle cell anemia. So let us move on to the treatment. So the first drug which is used in the management of sickle cell anemia is Hydroxyurea. Hydroxyurea is basically a hemoglobin F inducer, which is a fetal hemoglobin inducer. So we know that in sickle cell anemia, there is some amount of fecal hemoglobin which is coming up in your hemoglobin electrophoresis as a compensation. So if you try and induce the fetal hemoglobin, then the number of episodes of sickling may come down, right? So this is given at a dose of around 20 mg per kilogram. The newer drugs which are used include voxelotor, which basically increases the affinity of hemoglobin, okay, to oxygen, and thereby preventing the deoxygenation and reducing the sickling episodes. Third, we have the crinzalizumab. This is P-selectin blocker, which is a newer drug used in the management of sickle cell anemia. So this P-selectin is basically how RBCs attach to the vessel membrane, right? So if this P-selectin is blocked, they cannot clump and it cannot get attached to the endothelium of the vessels, and hence thereby reducing the hemolysis. Okay, so these are the various drugs which are used in the management of sickle cell anemia. Ultimately, sickle cell anemia requires transfusions from very younger age. So in acute hemolytic episodes, they may require. And also in prevention of stroke, if the transcranial Doppler is showing evidence of reduced velocity, then also they may require recurrent transfusions. Okay, fine. So this is how you manage the different syndromes and how do you manage or prevent sickling in sickle cell anemia. So till now we have seen the hereditary causes of hemolytic anemia. Now let us look at autoimmune hemolytic anemia, okay, which is one of the acquired causes for hemolysis. So first let us understand what is AIHA or autoimmune hemolytic anemia. This basically refers to, as the name suggests, there is an autoimmune process where there are antibodies which are produced against the RBCs. So autoimmune hemolytic anemia can be classified as warm AIHA and cold AIHA. So what do the terms warm and cold refer to? Warm basically refers to the AIHA where the autoantibodies are usually produced at temperatures of 37 degrees Celsius and above. Whereas cold AIHA refers to the temperatures at which the antibodies are produced, which is approximately at 4 degrees Celsius, right? So this is the basic difference in the terminologies between warm and cold AIHA. So let us understand what is the pathophysiology of AIHA. So in this autoimmune hemolytic anemia, as you can see, it is depicted here, there are antibodies which are produced against the RBC. So there are anti-erythrocyte antibodies. Okay, fine. So this is basically going to cause stimulation of the complement system. So there is complement activation with the formation of membrane attack complex. So this complement activation can result in destruction of the RBCs, resulting in intravascular hemolysis. Okay, fine. So this is how intravascular hemolysis happens in autoimmune hemolytic anemia. Also what happens is that there is going to be activation of the reticuloendothelial system and the macrophages and the phagocytes are going to phagocytize these RBCs which are coated with antibodies. Right, so there is phagocytosis, there can be fragmentation of the RBCs and a result there can also be cytotoxin mediated damage or destruction of the RBCs as well, right. So if this is going to happen, there can be some amount of extravascular hemolysis as well, right. So this is basically the three mechanisms of extravascular hemolysis by phagocytosis, fragmentation and cytotoxicity. So what we can understand from this particular image is that there can be both intravascular as well as extravascular hemolysis which can happen in autoimmune hemolytic anemias. So let us first look at the warm autoimmune hemolytic anemia, right? So what do you mean by warm? This basically means that the autoantibodies are produced at a temperature of around 37 degrees Celsius or more, and they basically react with the RBCs at that temperature. So warm AIHA often has an abrupt onset. It has an abrupt onset and there can be rapid fall in the hemoglobin as low as 4 gram per deciliter or lesser. So what are the clinical features with which they are going to present? They are going to present with hemoglobin drop. They are going to present with jaundice. What type of jaundice? It is going to be an indirect hyperbilirubinemia. Okay. So there is going to be both intravascular and extravascular hemolysis. So extravascular hemolysis is going to result in splenomegaly. There can be reticulocytosis and LDH levels will also be increased. Right? So this is very similar to many of the other extravascular hemolytic anemias. So what is Evans syndrome? So if autoimmune hemolytic anemia is associated with thrombocytopenia. Okay, so autoimmune hemolytic anemia with thrombocytopenia is what we call as Evans syndrome. Alright, clear. Now let us look at what is this Coombs test. Okay, so Coombs test is basically a screening test which helps us understand this autoimmune hemolytic anemia and helps in its diagnosis. So Coombs test can be classified into two types as direct Coombs test and indirect Coombs test. Okay, so the most important thing that you have to understand here is something called as Coombs reagent. Okay, so what is this Coombs reagent? These are basically anti-human antibodies. Okay, so they basically identify the human cells and the antibodies work against that. So the first is called as the direct Hume test or the DCT or DAT, direct anti-globin test. So in the direct Hume test, what do we do? So we basically take the blood sample from the patient who is suspected to have an autoimmune hemolytic anemia, right? So if you take the blood sample from the patient, the RBCs that you find will already be coated with antibodies, correct? So they already have some autoimmune antibodies in them. So this is what we are demonstrating here. There are RBCs which are already coated with antibodies on the surface. Now what we do is the patient's RBCs are washed off and they are incubated with this Coombs reagent. Okay. Now this Coombs reagent is going to go and attack any human antibody, and hence the Coombs reagent is going to go and attack these autoantibodies and RBCs as well. Hence this results in RBC agglutination. Okay. So this is your direct Coombs test. So what we have to understand from here is that the direct Coombs test or the DCT is basically going to identify the RBCs which are coated with autoantibodies. Right? So whenever this happens, the Coombs reagent reacts and then you find evidence of agglutination, and this is seen as a positive test in the tube. So now let us understand what is indirect Coombs test. So indirect Coombs test basically aims at detecting what? It aims at detecting the patient's autoantibody. Okay. So direct Coombs test was trying to detect the RBCs which are coated with the autoantibodies, whereas here in indirect Coombs test you are trying to identify the autoantibodies itself. So in the indirect Coombs test you take the serum. You take the serum which has the antibodies and then you add RBCs to it. Now since these are autoreactive, or since these are antibodies which act against the erythrocyte membrane, they are going to coat the erythrocyte membrane. Then if you add the Coombs reagent, which is basically the anti-human antibodies, then it is going to cause agglutination. Okay. So where do you use this indirect Coombs test? So especially if you are giving your RH incompatibility transfusions, then that is how you are going to identify this. Right. So this is where the indirect Coombs test is useful. So first let us understand the differences between direct and indirect. Again, direct Coombs test basically detects the patient's RBCs which are coated with the antibodies. But if you take the patient's serum and directly try and detect the antibodies, you add the RBCs and then you add the agent, Coombs reagent, and you see agglutination. So that is the direct and the indirect Coombs test, which is basically used in the diagnosis of autoimmune hemolytic anemias. So when we speak about warm autoimmune hemolytic anemias, it is classified as primary and secondary. Primary warm autoimmune hemolytic anemia is mainly due to genetic factors which are unknown. What we should be really worried about is the secondary causes for warm autoimmune hemolytic anemias, of which you really have to remember SLE. Right? Apart from that, we have CLL, certain lymphoproliferative disorders, myeloma, the newer drugs which are used in cancer chemotherapy, immune checkpoint inhibitors, post-stem cell transplant. The drugs which can be associated with warm AIHA includes piperacillin, methyl-dopa, ceftriaxone and cefotecan. Okay, so these are some of the most important secondary causes for warm AIHA. So how will you treat? If a patient presents to you with warm AIHA, how is he going to present? He is going to present with precipitous drops in the hemoglobin, severe anemia, correct? And they may also have indirect hyperbilirubinemia. And in the peripheral smear, what will you find? Like I had mentioned before, you may find the evidence of spirocytes as well. You may or may not find a splenomegaly, correct? So if you send the sample of this patient before a blood transfusion, then you may find difficulty in cross match, right? So if there is a patient with autoimmune hemolytic anemia who is presenting to you and you find that he is severely anemic, he is in anemia, he is in anemic failure and you want to transfuse him, you send the samples for cross match and you find that there is a difficulty in cross matching and the lab will call you for that. So in such cases, you will have to perform high risk transfusion, because whatever blood that you give that also can get hemolyzed, right? So you may have to take a consent and do a high risk transfusion under monitoring. Alright, and the treatment of AIHA, especially the acute treatment, involves IV corticosteroids, which helps in neutralizing these antibodies and bringing down the inflammation, and prednisolone is given at a dose of 1 mg per kg per day, right? Or you can give dexamethasone of 40 mg for around 4 days, or you give IV methyl prednisolone of up to 1 gram per day for 3 to 4 days, which is basically what we call as a high dose induction therapy, followed by you may have to continue steroids for a particular time. But many of these patients usually have a tough course. They may have relapse or they may have a refractory autoimmune hemolytic anemias, predominantly if they are secondary to your autoimmune disorders like SLE. So the moment they are off steroids, they can have a relapse of the AIHA again. Okay, so in such cases, you may have to give long-term steroids or you may have to give steroid sparing therapy, including azathioprine, and cyclophosphamide can be given in your SLE related AIHA. Rituximab is the second line agent, and sometimes the newer drug alemtuzumab, which is anti-CD52, has also been tried. Okay, so this is about your warm autoimmune hemolytic anemia. Now let us look at warm AIHA versus cold AIHA. What are the classical differences? So cold AIHA is basically an IgM mediated AIHA, and these antibodies are usually react at a temperature of around 4 to 30 degrees Celsius. Warm AIHA is predominantly IgG mediated, and hemolysis happens at a temperature of 37 degrees Celsius. So the primary cause for a cold AIHA is a cold agglutinin disease, and most of the time in warm it is idiopathic. Remember, the etiologies for cold AIHA include viral infections like EBV and CMV, other infections including mycoplasma, and you have to remember two very important malignancies which can be associated with cold agglutinin disease: Waldenström's disease and certain non-Hodgkin's lymphomas. Okay, but when we look at the viruses which can trigger a warm AIHA, it includes HIV, HCV, EBV, Babesiosis, and the whole list of disorders that we had just discussed: lymphoproliferative disorders, myeloma, SLE, CLL, and including after hematopoietic stem cell transplant, and the drugs. Okay, fine, and both of them can be associated with pregnancy as well. So this is about warm versus cold AIHA. Let us understand what is this paroxysmal cold hemoglobinuria. So this is a specific subtype which is a type of a cold AIHA, and it is commonly seen in children, and the specific antibody is called as the Doneth-Landsteiner antibody. Okay, this is called as the Doneth-Landsteiner antibody, and the trigger is often viral infection, and it is associated with intravascular hemolysis. Okay, so most of the time the prognosis is very good, and it does not require any treatment. It just requires conservative measures, monitor hemoglobin, and the child recovers. Then cold agglutinin disease is the prototype of cold AIHA, right? So we had seen the salient features just now. So you will have to remember the two most important malignancies which can be associated with cold agglutinin disease includes Waldenström's macroglobulinemia and lymphomas. Management of cold agglutinin disease predominantly involves the treatment of the underlying cause, and also whenever there is hemolytic episode, you may have to transfuse them. Okay, and they may require steroids intermittently as well. So with this, we have come to the end of our discussion on autoimmune hemolytic anemia. Thank you.